Good evening. So about how the people with uterine fibroid present. Presentation of uterine fibroids vary from individual to individual. There's a group of women who will come to you and tell you that, doctor, all of a sudden my periods have become more painful, and that could be a possibility that she has a mass within the uterus. There are those who will tell you my periods are much more heavier than they used to be, and then there are those who will tell you I feel as if there's a pressure or pain in the lower abdomen. And then there's a group that will be passing urine more frequently because of the size. Once the fibroids are growing, they kind of put a pressure on the bladder. And then there are women who will tell you that I have lower back pain, or when I'm having sex with my spouse, I feel pain these days. So those could be possible symptoms people with uterine fibroids present with. And when should you see a doctor? Generally speaking, I always say that if everybody was to be seeing a doctor because of uterine fibroid, all the women probably in the market would be coming to the hospitals, because 7 to 8 out of 10 women above age of 30 have some form of a fibroid. It may be 1 or 2, but very many are really asymptomatic. So when you have symptoms which I've outlined before, either heavy uterine bleeding, painful periods, or you feel a pressure, or you feel an obvious mass, I think it is the right time for you to be able to visit your gynecologist, so that he can be able to examine you and then do some kind of tests. Usually we do ultrasound to be able to see the extent of the uterine fibroids. About the management of uterine fibroids, as I said, because I get a lot of referrals from junior doctors, and at times I get self-referral from mothers with uterine fibroids. Management stretches from doing nothing to intervening in acute cases and having long-term solution. So generally, if a lady has done an ultrasound for a different reason, and incidentally it is noted that they have a uterine fibroid, and they come to me, and when I take history and I don't see really any symptoms suggestive that of the uterine fibroid, in most cases I will advise them not to be worried about the presence of the uterine fibroids. It's not very unusual that somebody can have a uterine fibroid, and in that case it will be advisable that they can do periodic follow-up ultrasounds just to see if the sizes of the fibroids have increased. So I usually recommend, if somebody has very minimal fibroids, really maybe probably after 6 months or even a year, that's when they can be able to do a repeat ultrasound to see if the fibroids have increased in size. That is in case they haven't grown very fast and the patient has developed any symptom along the way. But if a person comes to me with obvious symptoms such as heavy uterine bleeding, such as painful periods, and therefore it is extremely very important that we have to intervene. However, management of the symptoms is more or less like a first aid, because we would not want to see that somebody continues to bleed. Therefore you have to give some medicines such as non-steroidal anti-inflammatory. Examples are ibuprofen, diclofenac, plus other types of aceclofenac, mefenamic acid. All of those can be able to be given at times to take away pain, but also in their mechanism of action they can be able to reduce bleeding. And then there are other medicine group of drugs we call antifibrinolytic. They improve the clotting system at the tissue level and the bleeding site, and in the process they can also be able to prevent excessive bleeding. So the commonest example usually is tranexamic acid. And then of course there are times when we give patients drugs such as progesterones like Duphastone, because generally the way they work, it is to thin the endometrial lining so they'll be able to reduce or stop the bleeding, usually after taking for 5 or 6 days. So that is acute management of a patient who has heavy uterine bleeding. You can give pain management appropriately based on the severity of pain. Oftentimes we would want to give first line medicines such as paracetamol or Tylenol for that case, or non-steroidal anti-inflammatories like ibuprofen, diclofenac, which should be sufficient to be able to reduce pain. But if that cannot, and then you can go into drugs in low grade opioids like tramadol, which rarely we give, but in some situations some patients really have very extensive pain, like severe pain, and in that way we'll be able to give them pain management which is appropriate for their pain. Another medical management which I would call intermediate is really to give patients GNRH analogues. GNRH are gonadotrophin releasing hormones. These are drugs which stimulate usually the release of a follicle stimulating hormone and luteinizing hormones from the brain within the blood circulation. So usually when you give them these medications, they to eventually be able to cause some kind of initial flare effect. Then after that the patient will be able to all of a sudden shut down the brain from releasing excess of the FSH and this kind of thing. So when the follicle stimulating hormone and the luteinizing hormone levels are suppressed, in a way they also reduce the ability for the ovary to produce a lot of progesterone, estrogen, because the growth of the fibroids are mainly hormonal due to increased surge in estrogen and progesterone. So the best way is to be able to suppress that pathway. So gonadotropin relieving hormone, in most cases we give them for 3 months. Either you can give 1 monthly shot for 3 shots, or they are long acting gonadotropin releasing hormone antagonists, which are 11.25 milligrams, which you can also give as a single injection. The maximum you should give usually should be for 6 months, because when you go beyond that, then you will be able to drive this patient into menopausal state. So we usually don't want to give the medicines for too long. So 3 months to at most 6 months is a very sufficient time to be able to suppress. But because these women, if they are very remote from menopause, this drug at some stage the effects will wane off. So even then there are the side effects can be able to at times resume back. So whenever you are treating patients with this, you should be able to let them know that what you're doing is temporal, it is not a permanent solution. Of course, there are people who also have heavy uterine bleeding. Maybe the fibroids may not have affected so much the inner lining of the endometrium. In situations like that, you can also consider giving them progesterone intrauterine system, which usually the commonest is Mirena. You can be able to insert, and in a way it can be able to reduce the heavy uterine flow. However, majority of patients benefit a lot from surgical option, and surgical options here are of 2 types. One is really managing the myomectomy, the fibroids as it is, and that way we'll be able to do myomectomy. And when you do myomectomy, you're just going to remove you're just going to remove the what? You're just going to remove the fibroids. So for example, if you see this, it's a uterine fibroid. That is a uterine fibroid. So what you do is you'll be able to make an incision on the uterus and be able to deliver that. The same can be with that. So that's what exactly happens when you're doing myomectomy. And it's a very good procedure. It's a major surgery, but it's a good procedure, especially for those who have not attained their fertility needs. Meanwhile, there's a group of patients who may have achieved their fertility need and they really do not want this to be suffering with on and off bleeding. They will tell you, doctor, I'm tired. In a situation like that, if you're very sure that they have made up their mind very well, they have children, even some come with their spouses, once they consent to it, you can do what is called hysterectomy. Hysterectomy is a surgery where the uterus is removed. So usually when you're doing a hysterectomy, you do not remove everything including the ovary. In most cases we do simple hysterectomy. When you're doing simple hysterectomy, your target will be to mainly to remove the uterus, so the ovaries will be left aside. You cut on the uterus up to the cervix, and the vagina will also be left intact, and that way they will not be able to see their period, and that way they will also not be able to go into menopause, because the ovaries will still be working normally, and also their sexual function will be left intact. So that is a surgery which the surgical options which we usually consider for the patients, and there are no clear ways through which we can be able to prevent uterine fibroids. But one of the ways through which you can be able to do prevention of uterine fibroids is to ensure that you have a good weight control, because most of the hormones within our body, they are initially started from the progesterone level, from rather from the cholesterol, which is the fat deposit within our body. So if you are healthy, a normal BMI, not obese, that will be good for you. Of course, having balanced diet works very well. So it is also advisable that people should have well-balanced diet. That will be able to prevent unnecessary cholesterol deposition and things which can eventually lead to development of uterine fibroids. Also, those who have been using hormonal pills have shown to have less chances of having uterine fibroid, especially if somebody has not started it when they are too young. So those are the preventive mechanisms of uterine fibroids we know of. There are other management options probably I would have not covered here. If you want to be managed as an individual, I would request you to text me a message or write to me an email, and then I'll be able to respond to you appropriately on what best fits your management plan. Thank you very much. Please subscribe and share this video with your friends.